Good morning, good afternoon, and good evening to the members of the Pasteur Network community. Welcome to this new Pasteur Network monthly seminar. As usual, we'll begin with our speaker's presentation and we will follow it by a Q&A session. You are welcome to drop your questions in the chat at any time or ask them directly during the Q&A. And please remember to keep your microphone and your camera off during the talk to ensure a smooth experience for all. The session is recorded and will be available soon on our YouTube channel, so you can revisit it or share it with your colleagues. Today's seminar is titled Global.health Federated Data Platform Enabling Cross-Border Collaboration. And for that, we have the pleasure to welcome our speaker, Samuel Scarpino. Samuel Scarpino is a professor of public health and health science and director of AI Plus Life Science at Northeastern University. He also holds appointment in computer science, the Network Science Institute, and the RU Institute. He is a fellow of the ASI Foundation and external faculty at the Santa Fe Institute and Vermont Complex Systems Center. Before Northeastern, he was vice president of pathogen surveillance at the Rockefeller Foundation, chief strategy officer at a social impact tech startup, and co-founder of Global.health, a data science initiative supported by major foundations. He also served as assistant professor of mathematics and statistics at University of Vermont. Scarpino's interdisciplinary works blends public health, AI, and data science to support decision-making across sector. He has over 100 academic publications cited more than 10,000 times, and has been featured in outlets like the New York Times, NPR, and The Guardian. He frequently speaks at international conferences and public events. So I'm going to give the floor to Samuel, but before that, I would like to remind you that since October 6th, we have a platform called PNLink, and that's it. Sorry. Should have been right. And you might know that this platform is completely for free to all the members of the network. I mean, when I say all the members, is really all the members, not only scientists. And the idea of this platform is to create much more collaboration and to be much more informed of what's happening in the network in each institute and in the network more generally. So we are, in 5 weeks, we reach more than 500 people, which is great. But the idea is to have everyone from the network on the platform. Okay, so the floor is yours, Samuel, and I'm stopping sharing my screen. It's your turn. Thank you so much.
Wonderful. Thank you, Etienne, very much for the very kind introduction. Good morning, good afternoon, good evening to everyone. I'm very excited to be here to tell you a little bit about the work we've been doing at Global.health. Let me share my screen. All right. I assume that you can see the slides.
Yes.
Okay, and it's advanced to a picture of me.
Yeah, it's working.
Great. Okay, I'll skip the introduction because. As you already heard, I'm a professor at Northeastern University in Boston, and I'm happy to share the slides afterwards if there's interest, which contains contact information. Very briefly, a little bit of background about me before I go into Global.health. Most of my own research focuses on the genomic and epidemiological characterization of infectious disease outbreaks, and that ranges from well-established pathogens to re-emerging and novel pathogens. And I try to translate that work into the design and evaluation of public health surveillance systems, and this is done globally with partners from the local all the way up to the national and multilateral level. And I also engage in quite a bit of mathematical modeling to try to understand something about the dynamics of different kinds of infectious disease outbreaks. At Northeastern, I lead a life sciences and AI research group that spans the university and focuses on activities from biomarker detection and drug discovery to wastewater surveillance and precision health. And this involves work like data integration via ontologies and knowledge graphs. I'm showing an example here of looking at different kinds of febrile illnesses that may be indicated in a mortality report. And so if any of these things are of interest, very happy to set up additional time to talk with all of you. And last, before I move on to Global.health, I'm one of the co-investigators for a US CDC-funded center called EpiStorm that focuses on innovating around forecasting and outbreak analytics, primarily in rural settings in the US. And we also do quite a lot of work on wastewater surveillance system design and evaluation, both at the local level and at regional levels involving things like airport-based surveillance. This center is run by Professor Alessandro Vespignani at Northeastern University. Okay, so the background around Global.health is something that I'm sure all of you understand and have lived throughout your career, that from the perspective of public health and global health, whether we're dealing with an acute emergency or a long-standing challenge, cannot function well without good data. But I think it's useful for us to spend just a few minutes thinking about what we mean by good data. And this thought process is what led a number of us to found Global.health and build the data platform that we now use during the pandemic. Just a brief aside, it's also important to consider what we mean by the word data. And if we look at the definition in the Merriam-Webster English Dictionary, it lists data as factual information. And the reason that I put this up is that for most of our analyses, once we call something data, we're assuming that there's an element of truth associated with that measurement. And so part of the reason we need to strive towards good data and good data practices is that these pieces of information, whether they're digital or analog, represent our understanding of the world that we live in and the communities that we're serving. I borrowed this from the internet. There are so many examples that I don't actually know who to credit, who came up with this, but there's an idea from an individual named Maslow around the hierarchy of human needs that has been transformed into the hierarchy of data needs. And so at the very top, what we want to be able to do with our data is impact, improve the lives and livelihoods of the individuals in our communities and in our global community. And we believe in order to do that, you need to be able to run analytics on the data. And to do analytics, that means you need to be able to share data, whether you're just sharing data between, paper forms and then into a DHIS2 instance and into a dashboard, or whether you're actually sharing data between organizations or regions or between countries. To share data, you have to store it, and then all of this rests on the foundation of collecting data. An interesting sidebar is that Maslow actually took this idea from an indigenous group in North America, the Blackfoot Nation, and their idea of the hierarchy of human needs is not a hierarchy, it's a wheel where you're constantly improving yourself through reflection, physical activity, emotional, spiritual, cognitive well-being, where they say that change is a constant, inevitable, cyclical, and dynamical part of the human experience. And I actually think this is a better analogy for good data practices, that it's a wheel of continuous improvement and evolution as the needs of our communities and global society change, as technology changes, and as we respond to different kinds of emergencies. One other way to think about good data is from a book that I found quite informative called The Data Revolution. And I've simplified a more detailed description, but we could imagine it in different levels. So where level 1 data would be things that are not really machine readable. Technically, the data are available, but they're trapped, right? So this might be paper forms that we're recording information on. The second is that they're machine readable, but they're in a proprietary format, like in Microsoft Excel, for example. And here the data can be analyzed, but you typically have to use that proprietary software. And so while they're available, they're trapped and expensive to analyze and maintain. The third level is machine readable data and non-proprietary. So this might be like a flat text file, like a CSV, but it could also be a Postgres database, some open source platform. And here, the data can be used by most any software, but they're often challenging to analyze and share, in particular because they're not collected and tagged together with their metadata. And so ideally what we want to strive for, and this is the motivation behind Global.health's effort, is we want machine readable, non-proprietary data that's linked to the metadata and the schema around how it was collected. And these are the kinds of data that are most ready for analytics, machine learning, artificial intelligence. And the challenge here, of course, is that it requires technology. And that's what we've been working to build at Global.health. Here's a timeline of our organization. We were founded in January 2020 during the COVID-19 pandemic with a mission to enable rapid sharing of trusted public health data to advance the equitable response to infectious diseases over the first 100 days. So most of what Global.health focuses on are acute situations, either for novel pathogens like COVID-19 or for established pathogens like Mpox or Ebola or Marburg that are causing new acute emergencies that require a response. And one of the reasons that we constructed this data platform is because novel outbreaks or outbreaks of established pathogens that grow in severity in unexpected ways or show up in places that we weren't anticipating will strain the data systems and data collaborations that we have in place and that we leverage to control and respond to these outbreaks. And so what we do at Global.health is leverage a software platform to collect and organize data that's detailed, containing information on demographics, location, case status, symptoms, treatment, exposure, outcome, travel history. It's validated by humans, de-identified, standardized, ideally centralized and open, although I want to tell you about a federated platform that we're building, which is where we're looking for opportunities to collaborate, and licensed for non-commercial public use. And so these are the public data sets that we create, although as I mentioned, we often work directly with ministries of health or organizations like the WHO to create data sets as a part of a response that won't be made public. Currently, we work on data that occurs all over the globe. This is a map of data that were generated as a part of a recent response that we supported, where countries are highlighted by the number of cases that we've collected in the database. On the COVID-19 side, which we're no longer actively tracking, when we finished the active part of the response, we'd organized over 100 million cases from nearly every country, and these cases covered over 60 fields of metadata. And so in the end, over 1 billion unique data points, representing the largest public repository of line list COVID-19 data anywhere in the world. As we evolved from the COVID-19 pandemic, we started collaborating with organizations like the WHO Pandemic Hub via funding from organizations like the Rockefeller Foundation, Wellcome Trust, and others to build collaborative networks around data integration in support of things like pandemic and epidemic intelligence, but also international collaboration. We now have partners all over the globe, although you'll notice some conspicuous absences in places in Asia in particular, where we have fewer ongoing collaborations. And with organizations that include universities, but also groups like Africa CDC, the Humanitarian Data Exchange, where we post our data, Our World in Data, which leverages information coming from Global.health. And we do have active collaborations, although not formally a part of the Global.health network, with Fiocruz and Institut Pasteur in Dakar. In fact, two of us from Global.health were just in Dakar earlier at the end of the summer as a part of a Gates Foundation meeting around artificial intelligence and data. The team of individuals who lead Global.health represent groups from many different countries and also many different backgrounds, from individuals working in technology to individuals leading emergency responses, working inside of ministries of health, and also working inside of universities. And we're fortunate to have an amazing team of individuals, from data curators and data scientists to software engineers and product professionals, that help us maintain, develop, and advance the platform. Just a quick example of the kinds of things that we do on the public side. So we helped organizations like the WHO the Mpox in 2024. And as a part of this, we developed a data schema and a public database associated with Mpox cases that ended up representing almost 15,000 confirmed and almost 50,000 suspected cases through the end of our active engagement in the response, which was December 2024. And this represented cases that had occurred in 27 countries. And so we are able to generate reports on things like age distribution, shifting demographic information in support of the response, and make the data all publicly available via updated GitHub repositories that include information about the schema that was used to collect them, the provenance of the data, and necessary data use and access agreements as a part of the GitHub repository. And so this is the kind of level 4 data that I was talking about at the beginning, where you have data that's stored in a non-proprietary format and tagged together with the necessary metadata so that it's ready for downstream use and analytics. Briefly, to highlight the kinds of responses that we typically engage in, it's right around the time of the intervention. So somewhere after the initial cases are detected and as the response is ramping up, but typically not into the significant part of the intervention response, because at that time, ministries of health, multilateral organizations, other coordinating bodies will have come in with their own data systems. They may continue to leverage aspects of Global.health, but it's this early response period where we think our technology has the most to offer. And we've supported responses for avian flu in places like the US, Mpox all over the world, Marburg in Equatorial Guinea, Ebola in Uganda, and then COVID-19 globally. I want to highlight some of the work that we did with the avian influenza outbreak in the US because it demonstrates the One Health nature of the kinds of data that we're able to collect and render interoperable. And this is something that members of the Pasteur Network understand better than anyone. But in order to respond effectively, especially to emerging pathogens or persistent, epizootic threats, we have to take a multimodal approach to infectious disease surveillance that embraces the One Health nature of our interconnected human, animal, domesticated, and wild populations. And this means that we need to be able to collect and integrate case data with animal health outbreak data, genomic data, data coming from environmental surveillance programs, including wastewater, and then tie that to policy action, research, and response. And so that's what we did during the H5N1 outbreak last year in the United States, was to collect and integrate One Health data coming from all of these various sources. So genomic data, wastewater surveillance, human case, and animal health data. And these three together represent the kind of real-time cross-sector outbreak intelligence that we think is so critically important and needed as a part of our response to infectious disease outbreaks. And so we end up with open line list data that, as I mentioned, include detailed validated information on de-identified cases. We can then map and visualize those data. We can produce reports that look at things like shifting demographic trends, which can often be indicative of epidemiological patterns changing. And we can embrace a multimodal One Health approach to infectious disease response. And so we think that these three tools that we can provide as a part of our platform demonstrate the kind of cross-sector outbreak intelligence that's necessary to advance global health. And what I should mention also is that all of these tools that we develop, in addition to the data themselves, are open source. And so while we support responses as Global.health in terms of our data curators and building open data tools, we also can provide the software, or individuals can just access it directly off of GitHub for their own responses and use. And as I mentioned, we also have supported organizations, government and non-governmental, as a part of responses where data sets are not made publicly available, possibly because they contain sensitive information. There are challenges associated with data sovereignty and storage that don't allow for broad open access to information. Again, one of the reasons that to highlight the importance of this kind of multimodal data comes from the H5N1 outbreak that happened in California, but this is also indicative of exactly the kind of situation that we find ourselves in for all infectious disease responses. So here we have a time series of events that occurred from April 2024 through February of 2025. And on the far left here, this is around June of 2024 is the first place where wastewater surveillance picked up H5. It's not H5N1. The test is just for H5, but we assume that it's H5N1. And you can see that many months pass. It's August before you have the first detection in a commercial cattle herd, a little bit later before poultry farm, and then even later into the end of September before the first human case has occurred. And again, this is why it's so critical to integrate these various kinds of data into our infectious disease outbreak response, because the signals that we need to intervene quickly often occur weeks or months before our first detection in human or animal populations. And certainly if it's a situation where we have transmission potentially back and forth between human and animal populations, that there will be a delay between our first detection in either the human or animal settings and the detection in the other environment. And you can see the declaration of the state emergency not happening until many, many months afterwards, close to the end of 2024. And so again, part of the reason that we want to track policy interventions is because they often will lag significantly when the public health and One Health responses have already had to ramp up in response to both human and animal cases. Okay, what I want to do now is spend the remainder of the talk discussing where we think one of the directions of Global.health is going. And that's to allow for a different kind of data sharing. And that's data sharing where currently at Global.health, if the data are going to be made available publicly or to a consortium, they're all integrated in one location. Now that location can be, in a cloud facility in, a particular country, but it would be all integrated into that one cloud location. We understand that one of the challenges associated with data sharing is that data often need to stay at rest in the location where they were collected. And analyzing these kinds of data requires an approach that is now referred to as federated learning, where you have algorithms that are capable of inferring the parameters from data sets that are separated in different locations. And these algorithms can be quite simple. You're just taking, an average. So you look at a vector of numbers, you calculate the average, you store the number of numbers, and then you move that average and that n onto the next data set, and you continue to update your weighted average. Or they can be much more complicated, like fitting detailed regression models or epidemiological models, as well as training neural networks or other AI tools in a federated way. However, the the availability of some of these algorithms, although there's a lot of active research in this space and many things that we still don't know how to do with data that are stored separately via federated analysis, we often lack the technology infrastructure in order to securely access those data for running the models, and also to ensure that the data are interoperable, meaning that they have metadata standards. They don't have to have all the same metadata and the same ontology, but they have to be, the ontologies and the metadata have to be stored in an accessible way such that the algorithms know how to compute against the data. And so what we've been working on at Global.health is extending our platform to be able to function with distributed data, and then to be able to perform federated analysis across those distributed data. So to try to make this a little bit more concrete, I just want to share a couple of examples of what we might think of as user journeys here. And so this is, from the perspective of a user-centered design approach, what might we expect people to need to do with this system? And so there's a country that has an outbreak, and it's an established partner of Global.health. That Ministry of Health has collected outbreak data that they cannot share publicly, but there's been an agreement that organizations can compute against those data as a part of the public health response. So an example here might be for Mpox, we're interested in estimating something around the incubation time. And so in order to estimate the incubation time, you need data on exposure. And those exposure dates may be sensitive and something that can't be shared publicly. However, the ministry is willing to allow organizations to compute the incubation time from those data as long as they stay at rest, the data themselves stay at rest. And so we need to establish infrastructure and resources for secure data connection in order to run analyses without exposing the data to our compute environment or to the public, and such that the results of the computation leave the network, but nothing else. So agreed upon set of results will leave the network, but nothing else will leave the network. Another example is that a researcher needs to run recurring automated analyses against partnered data. And so you could be a researcher, at a different site in a network like Pasteur. You could be a researcher at, a regional health facility in a different part of the country. You could be a researcher in a Ministry of Health collaborating with a different Ministry of Health. So here, researcher can be within the same country, it can be within the same organization, but there are restrictions on the data being able to move outside of the storage location. So once the data connection is established, outbreak data are going to update regularly. So the model may need to run every day or every week or every month. And we want to have a system that can run automatically and return information. In this case, it might be managed by Global.health, but it could be managed by a Ministry of Health or by a non-governmental or multilateral organization. But importantly, there's a desire to have remote control over the ability to run models against the data. So in the first example, the first user journey, we may just have a one-off analysis that's going to be run. And in the second, we imagine that this is the kind of analysis that may be running regularly against the data system. So the requirements of the tool that we've been building is that the data needs to stay at rest in a partner-controlled compute environment. There needs to be a secure connection between the control server, which is where the model is going to be sent from, and the data server, where the model is going to be run itself and information will be returned back. Only analytics are going to be returned back to the control server, so the data needs to be able to stay at rest. We also, and this may seem like a bit of a niche point, but we need the ability to deploy code that's written in many different software languages, including R, against the remote data. And one of the reasons we highlighted this is that a lot of the work that's done on the federated learning side is in Python. And so many of the existing tools that people would use for federated learning have requirements that only Python code can be run or only certain languages can be run. And we know in the context of infectious disease responses that there's often many different kinds of analyses in different languages, bioinformatics workflows, all sorts of things that will need to be run. And so we need to have flexibility to run different languages. And then we need some way of standardizing the development of new analysis scripts. And so we need something that looks like an ontology or a structured way of organizing these analysis scripts. We also don't want to maintain a complex custom code base. And so what I mean here is we want to try to find open source tools that are being developed by communities of users that we can integrate into what we're doing at Global.health, as opposed to developing an entire net new set of features and functions that would have to be maintained. And for now, we're focused on data that are stored in the cloud. They can be in many different kinds of cloud instances, or reasonable alternatives that would be on-premises storage, but not all possible configurations of on-premises storage. That's a place where we think there's some interesting opportunities for future work. So just briefly, again, to review what's happening with federated learning is that you have some control server we have at the top here that's going to initialize a model. That model gets sent out to servers that contain data sets. The model runs locally. It infers parameters. It pulls those parameters back together together with key pieces of information like sample size, etc. Pulls all of those back to be integrated by the control server, and that model aggregation step is the final piece. And that aggregate model is then something that either can be made available publicly or made available to the various partners. What we've adopted as our framework for performing federated learning on distributed instances of Global.health data is a platform called Flower that's being maintained by a diverse consortium of academic and non-academic research groups around the globe. And so this is the first piece that we were looking for is, an open source, permissively licensed tool that's being maintained by a robust network of researchers. And so the way that federated learning would work in the context of Global.health is that we would have a control server that would be able to send out analysis scripts to multiple downstream servers that contain data that would run those analysis scripts and send back the agreed upon results, again, which in this case would not include the data. The data stay at rest throughout the process, but information from the analysis is returned back to the central server for aggregation. And importantly, none of this has to be made public, right? So all of this could still remain private. It's just that what we're solving for here is that the data sets themselves can't be aggregated. So if you have multiple network sites and they each have their own data sovereignty rules. So imagine you want to run an analysis with partner sites in India, in Kenya, in Brazil, and in France. You wouldn't be able, if there's certain kinds of health data, you wouldn't be allowed per those countries' rules about health data sovereignty to aggregate all of those data in a third-party location to run an analysis. Instead, what you'd want to do is run your analysis locally on the data stored on the sovereign soil of those partners, and then move the results back to a centralized location. And again, this is something that we could do as a part of a public response to an infectious disease outbreak, but it's also something that could be leveraged with the Global.health tools to be run, inside of an organization or as a part of a multi-organization collaboration that may or may not be made publicly available. One of the things that we had to develop was functionality to use the R programming language. So Flower has native Python utility, but not native utility for many other languages, R being a key one of them. And so what we've done is to develop an R integration with Flower that leverages some tools like RPy2, which translates between Python and R, and a data read-write service for Apache Arrow that allows us to move information back and forth between R and Python so that we can then execute R scripts via Flower. And this is the approach that we would likely take for more complicated workflows that would involve, bioinformatic pipelines, like if you wanted to do variant frequency estimation in wastewater data at a bunch of partner sites, but you don't want to move say the short read sequencing data off of the partner compute environment. You just want to estimate the variant frequency using your bioinformatic pipeline, and then move those variant frequencies, onto the next partner site to get a global estimate of the various frequencies. Okay, so what I'm going to do is wrap up here, because I want to have time for questions and discussions, because part of why we wanted to present to this network is we're looking for partners to help us co-create this federated response platform. And what we think is necessary are developing community standards around ontologies and schemas, common data models, APIs, opportunities to build more human-in-the-loop AI data integration that respects data sovereignty and the ethical and equity principles that we all hold important in the global health community. Federated data models, including compute infrastructure. I've shown you one example of what we're working on in Global.health, but there are many others. In order to accomplish this at scale, we're going to need shared legal and ethical frameworks for data access. And so if we're now no longer thinking necessarily about moving data into a central location, but accessing data as a part of a public health or global health initiative, we still need the right legal and ethical frameworks in place. We also need multi-stakeholder engagement around technology and data needs. And this includes things like the development of new cloud data centers, but also the ability to perform ambient intelligence, compute on edge devices, work on various kinds of on-prem compute environments. And increasingly, we need to collaborate around training for the next generation of health data researchers and policymakers. And so I really appreciate the opportunity to share with all of you the work that we've been doing at Global.health over the past 5 years, and what we think is an exciting opportunity to foster more international collaboration around both emergency response, but also ongoing active responses for persistent health threats via federated learning. We are looking for collaborators and partners, and so if you're interested, again, my contact information is in the slide deck, but also available via the website. If you just type in global and then a period and then health, so global.health, but don't spell out the word dot, you can find us on the web. That includes all of the data, links to all the code that's open source, as well as our contact information. And so again, I want to thank you all for the opportunity to present. I also want to thank you all for all the incredible work that you do to advance the health of all of our populations, and the international collaboration that's more important now than ever. And I am looking forward to spending hopefully the next 10 or 15 minutes answering questions and discussing. Thank you.
Thank you so much, Samuel. Thank you for your speech and for this very interesting presentation. I think there are many things that could be done together. We're opening the Q&A session. If someone has a question. Yeah, Michael White from IPPEP. Please.
Hi, Samuel. Thanks. That was a really great presentation, and it's very impressive and worthwhile effort. I have a question. It's a tiny bit off topic, but I think you might have something to add. Researchers in the network and beyond, in especially areas where there's lots of outbreaks emerging, spend a lot of time generating data and putting a lot of effort in. And one thing that I think some of us struggle is the tension between getting the data out and published and then keeping it to allow people to get publication. So for example, you might have a situation where you've got a PhD student who has put a lot of effort into collecting and generating a data set, and you know it's going to take them, say, 6 months to write the paper. And you could put all your, but you know this is useful data, and you might want to you want to get it out, but you know, if you share it, then somebody else can swoop in and take it and do a much fancier paper in 2 months. So I'm wondering if you have any solution for that tension between, you know, is there a way that you can share data but say, hey, don't publish this? Or, you know, is this the type of challenge that people have come to you with before?
Yeah, I mean, it's a great question, Michael. This is a challenge that, you know, we've all faced for a long time in the space. I think the area where I've seen a lot of progress is, you know, more collaboration and sort of shared values around not scooping people if they post data, you know, that you reach out to them and you discuss collaboration and you respect their right to perform the research that they're doing without being scooped. And so one, I think, is just more international collaboration and discussion and partnership around shared values. But this is a place where I think the federated nature of data storage could help, right? So you would have rules that would be agreed upon. And so we would write down what our shared sense of values are around, okay, these data are being made available as a part of a public health response. But until, you know, this flag is flipped to yes, you know, if you want to publish on the data, you need to contact, you know, this person and clear it first. And it could always be that way, that you always need to contact the person. And you know, you still wouldn't have that enforcement mechanism. People could always be bad actors if they wanted to, but you would have a codified record of what had happened and who had accessed the data and how it had been used, and a codified set of sort of norms and agreements that people would be signing on to. So I think, you know, for me, there's no way really to prevent bad actors from being bad actors once we make data available. But I think what we can do is set down a shared set of values and leverage technology to make data available around those shared set of values. And I think that'll get us a lot of the way there.
Okay, agreed. Thank you.
Thank you for a question, Michael. Noel?
Yes, so I'm following on the question of Michael indeed, but you know, a bit maybe in a different way. For example, when you are doing a scientific publication and you have to publish a result, and you are saying that only the results are shared and not the data, but in some scientific publication we are asked to give the data in order for the reviewer to know that the result is good. So how are you managing in this point? I have a second one, which is how are you interacting or whatever with with a number of data hubs that exist in the world, for example, GSAID during COVID and all that. And the third one, sorry, is you are talking about data about epidemiology, risk diagnosis, and we have a program, for example, in Pasteur, which is climate change and health. So are you also connecting data with some data of climate that you could put together? So yeah, 3 points. Sorry.
Yeah, no, all very good questions. So I want to stress that. So even though I'm an academic, I don't publish a lot of the work that I do on the global health side of things, and that's true for all the members of the Global.health network. So many of the responses that we're involved in, we may not publish as a part of that, or if we publish, sometimes it's a description of what was done in terms of the collaboration, not necessarily on the results right away. So I do think there will be plenty of situations where you want to publish something about what happened so that the world can better understand it and evaluate it, but that we shouldn't prioritize publication over the response. However, in the case where we do want to publish and we might have federated data, I think there are two approaches that we can consider. One is, you know, if we want access to data so that people can recreate and validate and vet the science, you could provide access via the federated platform for interested reviewers and others to to run their analysis themselves and vet and evaluate the work. So I think one mechanism would be to provide access to the data via the federated platform for people to run, their own analyses as a part of their evaluation procedure. I think the second, and it's related to your comment about the multiple different groups, is we should have a lot more interoperability between these various data platforms, right? So I think GISAID is an interesting example, right? Which is, I really wish they had a mechanism where I could have an API key that would indicate to GISAID that I have signed onto their agreement and that I'm a member, and then that would allow me to run analytics against the database to recreate somebody else's workflow. And they have the EpiSet now, which helps a little bit, but it still could be much more streamlined. And I'm not picking one group to sort of say that there are problems, but if you think about almost all the various data repositories that exist, there's not, for many of them, a lot of interoperability between them, and it's often quite cumbersome. And I think we could be using technology to help with that integration. And so instead of trying to have one data set or one data system or data ontology, if we have libraries of these ontologies and we have shared technology for accessing, then data can stay in their own repositories, but multiple groups and teams can access them under the rules and agreements that we've all put in place as a part of our community. To your final point, I think that for me is the really exciting opportunity. We know that if we're going to study climate and health, you have to be able to bring together sociodemographic data, information on urban, rural, detailed climate data together with infectious disease data. And that's a huge opportunity space to leverage all the work that we're doing internationally. This is actually ongoing work that we're doing, for example, with Fiocruz in Brazil around dengue and climate that Moritz Kramer is leading out of University of Oxford. And I think from my perspective, there's really no way that we can make progress on the climate infectious disease space without collaborating across countries and institutions, because one, the scale of the problem is too big, but in order to really disentangle the mechanisms, you have to be able to look across countries and jurisdictions, right? So a great example in India, dengue wasn't around really 20 years ago. Now it's widespread throughout the country. And the question is, how much of that has to do with urban, rural, and changing demographics versus climate change? It's certainly both of those are playing a role, but being able to look at analyses that are being run in many different countries to try to tease apart mechanism, both at the global level, but also then bring that back to the local level to help governments and responders better understand. I feel like that's a great opportunity space and something where we really need more collaboration. But the data integration part is a big challenge, and that's a place where we see a lot of opportunity for technology tools to help.
Thank you.
Oh, sorry, I was muted. Thanks a lot, Noel, for a question. We have another question from Mauro in Brazil, Sao Paulo.
Yes, thank you, Dr. Scarpino. Thank you so much for your talk. It was very interesting. My question is actually about how do you engage with policymakers and others, to those that will take action and look at your tool? Because from what I learned, and I work on the climate and health program from Pasteur Network, from what I learned is exactly that you have to bring them to the table while you're building your federated learning platform. And do you in contact with them? Do you engage them do you get their feedback? Because they are the ones who are going to make this tool useful, right? That's my question.
Yeah, that's deeply important and a part of the process from the very beginning, because as you understand, and everyone on the call understands, every government agency is different across, even within a country, and then, depending on who's actually the people themselves change. And so what they think are important, how that aligns to strategic initiatives, what they're worried about, what they understand, what they don't understand, it's all very personal and very local. And so spending time to really know as much as possible about what are the decisions that are being made, how could data like this help benefit individuals on the policy side, at the local level as well as at the regional, national, and multinational level, is critically important. One example that sticks in my mind, although we're not working on this directly, but I think it's a great example, is the Wolbachia trials that are happening across Brazil, and differences between what's happening in Rio versus Sao Paulo, and the interaction of the pesticide that's being used, and the climate change, and again, like the pressure that's happening from the policy side of things. That's a real opportunity to engage with policymakers around what kinds of things they need to understand better, how this fits into their response. In India, we worked closely with the government in the state of Karnataka around the dengue dashboard that was developed. The same, with organizations as a part of the MPOX response. And also sort of the question that I thought maybe Noel was going to ask was about sort of how we can use technology to ease the data collection and interoperability piece. And that's something that policymakers often care a lot about, because they're spending time and energy integrating data sets and getting pressure to make them public and put them on a dashboard. And so just adding technology that can help with those aspects of the job can really help build a lot of trust and strengthen those relationships and bonds. And so I think, yeah, just your point, Mauro, is critical, that you have to engage from the beginning with the policymakers, ideally also with the community members that are being served, so that they understand something about the data and what the data are being used for, and they feel that they're included in the process of what's being made public. Again, because part of the challenge with data sharing is that governments think, oh, well, the tourism is going to stop if we share our data on a particular pathogen. And that's something that you have to, and that happens in every country where I've ever worked, and so and lived, and so you have to have those conversations and build that trust from the very beginning, to understand, what it is we need to use the data for to help the response, and what we can make public that will not necessarily impact the tourism. But again, we also know that things happen, like in COVID, with South Africa doing the right thing and sharing the information on the Omicron variant, and then the backlash from countries like the US and others around the travel bans. And so, this is a really hard problem that, again, just takes time and trust. But I think focusing on building, big multi-network data networks is a way that we can help, build that trust and build those personal relationships that matter in terms of developing these things, and then being able to respond, quickly when there's an emergency.
Once again, I was muted. Sorry. Thanks again, Mauro, for your question. Yeah, it's important to, because one of the when I'm hearing all the discussion is also what is actually the role of the researchers in all that. And now, since and I think that more specifically since the last pandemic, the researchers has to be more and more involved in policy making, and engage much more with the policymakers and civil society organization as well. Do we have any other question? Okay. Okay. So I think there's no further questions. I would like to thank our speaker, Samuel Scarpino, for his time and his presentation. And I think there are many avenues for collaboration between our both organizations. I hope to see you all on December 11 for our next monthly seminar with Philippe Buchy from Institut Pasteur du Laos, and for the last seminar of the year. And once again, thank you so much, Samuel, and hope to see you soon.
Bye-bye.
Thank you so much, everyone.
Bye.
Bye-bye. Thank you.
Thanks.